let's turn to EGFR mutation positive disease in a setting that is common, and that is locally advanced unresectable lung cancer, where the standard of care historically has been chemo and radiation concurrently, and then followed by Durvalumab, Imfinzi, and that's based on the Pacific trial. This has changed practice overwhelmingly, and importantly, the patients with an EGFR mutation were permitted to be on this study, and the study was highly positive for an improvement in progression-free and overall survival, and it wasn't a small difference, it was a major difference. However, some of the early subset analyses suggested that patients with an EGFR mutation may not benefit. Of course, that's been our presumption as a general concept from patients with advanced disease. But this question still persists in our clinic. Both, should we be broadly testing for molecular markers in settings earlier than stage 3, like earlier than stage 4, like stage 3, and should we be excluding patients from this approach of consolidation immunotherapy if they were part of the trial that was positive, but we think they might not benefit. There's also a particular risk if they're on immunotherapy and then have progression, that we would want to start them on EGFR inhibitor therapy as the next best treatment for them, that for relapse, which is often going to be Tagrisso, osimertinib. We know that there's an increased risk of pneumonitis, severe and potentially life-threatening inflammation in the lungs. So there's no one better to speak on this than Jarushka. Dr. Naidoo presented this in a poster at ASCO, just showing the limited subset of patients with known EGFR mutation and indicating there was no improvement in progression-free or overall survival. Jarushka, I'd welcome you to comment on this in general, and then speak to what do you do? What do you say for a patient where we know the outcomes are not spectacularly great for chemoimmunotherapy, chemo radiation alone? You can have patients cured, but we've never been complacent or happy about those results before the consolidation immunotherapy. And we still await results of the important so-called LAURA trial that we'll be giving Tagrisso after. So where do you think this leaves us right now? What can you say?
Well, I think these data, similar to the FDA pooled analysis data, are in the eye of the beholder. And certainly standing at the poster was very interesting to hear the different takes on the same data. I think how I interpret this is that there is no clear benefit for Durvalumab in this subset of patients. And that in my practice, I generally don't give Durvalumab to patients who have EGFR mutant non-small cell lung cancer because I do not necessarily see a convincing benefit. Having said that, we understand that this is a very small proportion of patients that were enrolled on Pacific, and this is certainly not a study that was balanced. And we highlight this in the poster presentation that, you know, these patients who got Durvalumab versus a placebo weren't necessarily balanced for other factors that may affect overall survival or progression-free survival. So really very difficult to interpret. Having said that, these are the only prospective data we have so far to inform this question, so I think it's useful to look at. This doesn't give us any information regarding toxicity about what happens after the Durvalumab. It does tell us that these patients don't appear to have worse toxicity from the Durvalumab itself, but I think the question really is, when they get subsequent TKI, is there a synergistic effect that leads to a higher rate of pneumonitis? And in retrospective studies, we have seen that to be true. So we are trying to dig out that data and hopefully have something substantial to say in that regard. But I think that is the question. Interesting, again, like I said, different viewpoints coming through. I think others thought, well, I'm not necessarily doing any harm by giving the durvalumab here. And if I want to give it, or a patient prefers to get it, then this data may provide some reassurance. So I think, again, in the eye of the beholder, but certainly this beholder is not going to be given durvalumab in this circumstance. And I do test for EGFR mutations in this circumstance. Gilberto, what do you think?
So does this beholder, I agree. So we may not yet be able to give specific therapy for these patients, but I have been using molecular markers as a way of selecting which patients are more likely not to benefit from them. So I would agree with Dr. Naidoo on this one as well. Yeah.
You know, and it's interesting. My views have evolved somewhat. I would say my threshold for a subset is different when you're deselecting a standard of care now, you know, that not showing a benefit in a subset that's very small when it would otherwise be the standard of care. I think you need, to me, to have a different threshold for opting against something that you would otherwise give. You know, so not showing a benefit, I can understand the argument, well, if you don't know, or it might be beneficial, you know, this is not like the retrospective studies from FDA, the definitive answer that it absolutely categorically is ineffective. That said, I have really evolved as we've gotten more data from this and various other settings to being not particularly enthused about it. I would just offer it, discuss it with the patient, and be not particularly encouraging, but not necessarily prohibitive of a patient who is motivated, understood it, and said, I want it. That's all. But I don't think we're really very off on this. And I think this all may be obviated by, you know, a wildly positive study with Tagrisso in this setting, for instance, but we don't know that yet.